Hi, welcome to another ILD Community Network podcast. The ILD Community Network represents a groundbreaking collaboration between the Association of Pulmonary Advanced Practice Providers, or APAP, and Rheumatology Advanced Practice Providers, or RAP. And together, these organizations are committed to advancing multidisciplinary education, fostering collaboration, and improving care for patients living with interstitial lung disease. I'm your host, Amanda Mixon, and today's episode, How to Differentiate ILD Progression versus Treatment Failure, will explore one of the most challenging aspects of managing patients with interstitial lung disease. Determining whether worsening symptoms, declining lung function, or evolving imaging findings reflect natural disease progression, inadequate treatment response, or another contributing factor altogether. Joining me today is Jenny Williams, an experienced clinician and educator with expertise in the diagnosis and management of interstitial lung disease. Together, we'll discuss practical approaches to Together, we will discuss practical approaches to evaluating changes in disease status, review the clinical, physiologic, and radiographic clues that can help guide decision-making, and also when treatment strategies may need to be adjusted. Jenny, thanks so much for joining us today.
Thanks. Really happy to be here.
Can you tell us a little bit about yourself?
Yeah. My name is Jenny Williams. I am a PA at the University of Colorado. I work in lung transplant, interstitial lung disease, and sarcoidosis, and have been doing that at the U for about 5 years now, which is crazy to think about it.
It's so nice that we get to do this podcast together because we actually share a lot of patients together.
That we do.
And I've been so, fortunate to get to work with you and be able to, send you messages on patients. And it's just been so awesome having this collaboration. And I want every advanced practice provider, whether you're in rheumatology or pulmonology or primary care, to have access to subspecialty care like you. I mean, you're so specialized. And it's just so needed. So thank you so much.
Yeah,
okay, well, let's go ahead and get started with some of these discussion questions.
Yeah.
So to begin, when we talk about ILD progression versus treatment failure, how do you define each of those concepts and why is it important for clinicians to distinguish between them?
Yeah. Well, starting off with the hard-hitting questions, Amanda.
Absolutely.
Honestly, this is a question that I ask myself regularly in clinical practice. And honestly, there's not a lot of guidelines for it. There's a lot of gray area. There is no black and white protocol that we can just follow. But there are kind of clues that we can look at that kind of gears us one way or the other. And with ILD progression, I think about it as having clinical, radiologic, or physiologic indicators of progression despite having optimal treatment management for that specific fibrotic ILD. In recent years, this has been termed progressive pulmonary fibrosis, which we will go into detail more later in the podcast. And then when I think about treatment failure, again, there's no clear definition for this, but I think of it more as a clinical assessment that a specific therapeutic intervention has not achieved its intended goal. Some examples of that would be like antigen mitigation for hypersensitivity pneumonitis. We take away the antigen and they progress. So that may prompt me to do mycophenolate or steroids or even anti-fibrotics. Or in the case of rheumatoid arthritis-related ILD, sometimes we'll have patients who are on abatacept and tocilizumab for their joints, and they're well-controlled joint-wise, but then for their lungs, they're progressing. And so that might prompt me to talk to someone like you and say, hey, why not try switching therapy to rituximab or adding on therapy with mycophenolate, just so because we have more data surrounding those medications in ILD, or, relapsing organizing pneumonia in our myositis patients with ILD that may prompt us to escalate therapy further if they're on Ritux and they're having this relapse, restarting steroids, considering Cytoxan, those types of things, I think are good examples of treatment failure. But it is important to distinguish between these two because obviously the treatment is very different. So we need to make sure we can kind of decide what is happening so we can get the patient the best possible treatment plan.
Absolutely. Well, so let's kind of get a little bit more into this concept of progressive pulmonary fibrosis, or PPF. It's received significant attention in recent years. What clinical, physiologic, and radiographic features are most useful in identifying progression despite ongoing management?
Yeah. A fun statistic is approximately 18 to 32% of non-IPF ILD patients despite initial treatment, will progress in 5 to 7 years. So in other words, the majority of patients do well on initial therapy and they stay stable, which is great. But for that minority of patients that are progressing despite optimal treatment, I kind of think of it as a ILD triad, if you will. So you have symptoms, physiology, and radiology. And for the definition of progressive pulmonary fibrosis, you need 2 of the 3. So by symptoms, worsening shortness of breath, cough, O2 requirements. With physiology, absolute decline in FVC by 5% or greater than 5%, and DLCO by greater than 10%. And with radiology, we're looking for signs of worsening fibrosis. So that's worsening traction bronchiectasis, reticulations, ground glass opacities with the traction bronchiectasis, new honeycombing, new or worsening volume loss. But if I have a patient on optimal management with these features, then I think that would prompt me to think, hey, this is progressive pulmonary fibrosis. Maybe we need to consider add-on anti-fibrotics.
It's really good to know that most of our patients will actually do well.
I know.
So that's encouraging. I'm definitely going to talk to my patients about that. Because I think when they are diagnosed with any form of interstitial lung disease, that's so scary for them.
Yeah.
And of course, they do their own reading and have determined that now their life expectancy is 3 years, and so I think it's important that from a rheumatology perspective and, primary care, that we understand that, these patients can and most likely will do well. I mean, we obviously have to monitor them super closely, but talk to me about, if a patient reports worsening dyspnea or cough, what steps should our listeners take before concluding that their current therapy is no longer working?
Yeah, I think step 1, you got to think about other etiologies for shortness of breath. We can't chalk it all up to the progression of their underlying ILD. We want to rule out any sort of reversible causes. So just thinking differential for shortness of breath, you have pulmonary hypertension, you have to think of any sort of cardiac disease, PE, if they're having respiratory muscle weakness or other muscle weakness, especially if they have a background autoimmune disease, sleep disturbances, anemia, psychosocial factors. There's a lot of things that play a role into shortness of breath and we should look for. But using that in combination with physical exam findings, we can really get a clue in as to the etiology of their shortness of breath. And once we kind of figure that out, we can look into their pulmonary function tests, the 6-minute walk test, high-resolution CT, labs, echo. All of these are very helpful for distinguishing kind of what's going on and if this does represent treatment failure, progressive pulmonary fibrosis. And again, considering those anti-fibrotics, if at the end of that workup we decide this is progressive pulmonary fibrosis, so we can try to slow down the progression of their disease.
The other one that I kind of sometimes think about or that I often forget about is the GI component, right? Like they've got really bad reflux and they're aspirating or then maybe that's why they're coughing. And so I try to, ask my patients about those things, but it's super helpful to really think about, it doesn't automatically mean this is a progression. Like it could be, to your point, something else, cardiac, pulmonary hypertension. I mean, all of those things. I think that's such helpful clues for us to make sure it's not something else.
Yeah, exactly.
You talked about pulmonary function tests. So, we know that plays a critical role in monitoring patients with ILD. So how should clinicians interpret changes in FVC, DLCO, and exercise capacity when evaluating whether a patient is progressing?
Yeah, I think PFT data is a very useful and radiation-free way for us to monitor our patients with ILD, which is fantastic. But I think we need to, when looking at the PFTs, we kind of have to look at the whole picture. So we have to listen and have a conversation with our patient and kind of gather a history from them, focusing more on PFT trend versus one absolute value. And, obviously the exception to that is if someone comes in acutely ill with worsening shortness of breath and they're doing stable and all of a sudden their PFT's tanked, I will take that seriously, and do further workup. But I think there are reasons people can have a slight little dip in their PFTs that technically looks like progression, but isn't. So as silly as it sounds, some patients will have a bad PFT day where they feel like they don't have the chemistry that you should with the respiratory tech, or, their effort just isn't as good, or they could have recently had a viral infection. And so even though they're improving, their PFTs may still not be back to their baseline. Or if they had a recent prolonged hospitalization, they're really deconditioned. They had a recent surgery, so they're not exercising. All of these are factors you want to take into account when interpreting the PFTs. And I would have a low threshold just to repeat it, a little sooner, maybe in 6 weeks, 8 weeks, and just see, does it pop back up to baseline? Are we okay? Or do we need to consider further workup? But as for what is considered significant in the INBUILD trial where they looked at nintedanib in progressive pulmonary fibrosis, they used the criteria FVC decline greater than 10% or having FVC 5 to 10% decline in combination with symptomatic or radiologic progression. So you could use that as a baseline. You'll hear all these different numbers, but kind of looking in the 5 to 10% range for FVC, especially if it happens time again, should perk your ears up for further workup and evaluation.
How often do you do PFTs? I mean, obviously you would repeat them if somebody's worsening, but let's say you have a stable patient. And I'm thinking more about the people that practice rurally, and maybe they are kind of the primary one managing this, or maybe they're working with their local palm, but they don't have access to, a Jenny Williams at Anschutz. So how often should they be doing PFTs?
Yeah, that's a great question. And again, there's no hard, fast rule for this, but our clinical practice is typically every 3 to 4 months. People are getting repeat PFTs. If someone has been stable for years and years and years and years, I'll probably extend that out to every 6 months. But in general, our rule of thumb is usually every 3 to 4 months.
Okay, awesome. So let's kind of switch gears a little bit and talk about imaging, which is always very complicated for me to understand, what the images actually mean, what does this CT show, etc. So we know that imaging can sometimes reveal changes before symptoms become obvious. So what high-resolution CT findings are most concerning for progression, and how do they influence your treatment decisions?
I think a key risk factor that I look at when evaluating an HRCT is if they have a UIP pattern, so a usual interstitial pneumonia pattern. That is definitely more concerning that they will eventually progress. So I think that's definitely a alarm feature that you should think about. And then as far as when you're looking at the actual radiology CT scans and trying to decide, has this changed from the last time? That's when I'm looking at if they have any worsening traction bronchiectasis, those reticulations, ground glass with the traction bronchiectasis, new honeycombing, worsening honeycombing, and the volume loss, because that all makes me think more progressive pulmonary fibrosis, and I would lean more towards anti-fibrotics. However, if I'm looking at the CT and I see kind of superimposed ground glass opacities on their background ILD, I start to think of more acute etiologies, such as like an exacerbation of their underlying ILD, if they have something infectious going on, or as you alluded to earlier, like aspiration, all these things, that CT can definitely clue us in as to what's going on.
So same question about the PFTs. How often should we be doing? I mean, obviously we hope that we're working with someone like you or you'll be doing them, but if not, how often should we be doing this?
Yeah, I think it really depends on the clinical context. So if I'm really concerned and this patient is rapidly progressing, I'll consider repeat CT in 3 to 6 months. If there's someone where we did a recent change in therapy, I usually do a year for a follow-up CT. And then following that, it's kind of every 1 to 2 years, depending on the person. Sometimes I'll extend it even further if, again, they've been very, very stable for many years. But I know that's not a very easy kind of, you have to do it like this every time.
Yeah. But it's like that for us too. And like, radiographs for people with rheumatoid arthritis, like, not everybody does them every year, maybe every couple of years, maybe every 5 years. So it really just depends on the patient. So I totally understand that. Okay. So once, progression has been identified, how do you determine whether the next step should be switching therapies, optimizing the current regimen, or layering an additional treatment strategy?
Yeah, I think the best way to answer this question is actually through some examples. So if I have a patient with idiopathic pulmonary fibrosis and they're on anti-fibrotics with pirfenidone or nintedanib, and they're progressing on that regimen, then I would consider adding on therapy with nerandomilast to see if we could slow down that progression even further. I typically only switch anti-fibrotics if they are having side effect intolerance. So to improve their quality of life, trying to switch them to something that they could potentially tolerate better. Another scenario is someone with fibrotic hypersensitivity pneumonitis, and we have them on mycophenolate and they're doing very well and they're stable. And our practice is after X number of years with that stability, we'll start kind of dose reducing them over time to reduce potential side effects or adverse events. And so in those patients, if let's say they start to progress again, when we are doing that dose reduction, then we would bump them back up to that optimal dose that they were doing well and even consider the add-on anti-fibrotics. I think in the case of SARD ILD or the systemic autoimmune rheumatic disease related interstitial lung disease, love that they changed that. I think that should really be a multidisciplinary discussion with rheumatology, because, we don't know what's going to help to control their joint disease or their cutaneous manifestations. And so working with you guys very closely, we can decide, do we need to add on therapy if things are progressing as far as like maybe we're seeing that relapsing organizing pneumonia, or maybe we're seeing progression fibrotic wise, then we would work with you guys to kind of figure out the best course of action.
Well, we know, you just mentioned multidisciplinary, and I think that is so important that we discuss that. It's considered the gold standard in ILD care. How can collaboration between pulmonology, rheumatology, radiology, and APPs help clarify whether a patient is experiencing progression or treatment failure?
Yeah, I think first, I want to stress the importance of MDD for achieving the right initial accurate diagnosis, because with an accurate diagnosis comes appropriate treatment and the best possible chance of success for our patients. So working with a team just as far as longitudinal care in ILD is very important. I can't tell you the number of times I'm calling or emailing our radiologists and saying, hey, can you look at the CT? And they'll help to kind of define some of those features that help us decide, is this progression? Is this treatment failure? And then from there, kind of discussing with our pulmonologists and rheumatologists, kind of what we alluded to before about the best next steps of care. And I think as an APP, in my clinical practice, I am seeing more of the acutely ill patients when they're coming in because they can get in with us fastest. And so I kind of view myself at times as the maestro of their care, and I'm helping to coordinate everything and communicating with everyone. And I think that's really crucial in getting the patient the best care possible.
And I think it speaks to the point of, if you have the opportunity to get that patient into a center where they're going to have, that multidisciplinary care. I mean, from my perspective, when I have a patient with ILD, I love when they go down to your clinic, and I would have absolutely no problem with them seeing, the rheumatologist like Dr. Griffith or, so that they can kind of, give their recommendations as well, because I assume you all are kind of sitting around a table and saying, okay, this is what I envision anyway, that, okay, you have Miss Smith, and Miss Smith has ILD, and it's from her connective tissue disease. And, there's the radiologist that's going to look at the images. And so that everyone can kind of come together, because in the community, we really don't have that. Mm-hmm. And so I think it's just so important that, if you have the ability to get your patient to one of these centers, even if they can go once a year or every other year, having that ability to pick up the phone and talk or have access, I think is so important, right?
Yeah. Oh, absolutely. And it is kind of like all of us sitting around in a table.
That's what I
assume. And I think it's also really important to also include the patient in these conversations, because some patients will just kind of go willy-nilly and do what you say, but there are others who really want to be more involved in their care and who have strong opinions. And so I will ask them and tell them, like, these are your options. And a lot of them will say, I want to do this, or I would prefer this way.
Yeah.
So I think it's all very important.
I have a patient that refuses to get rid of her bird, Chloe. And her. And it's, Chloe is her family member, and it's a parrot, and she just will not get rid of Chloe. So no matter what we tell her.
They'll do what they want to do.
Yes. All right. Well, looking ahead, what practical framework would you recommend our listeners use when assessing a patient with worsening disease so they can make more confident decisions about therapeutic escalation and long-term management?
Yeah, I think the first step, don't forget to consider alternative etiologies for respiratory symptoms. And then, if there is reversibility, you don't want to miss that. Mm-hmm. And then once you've ruled those out, remembering that triad of PPF, so symptoms, physiology, and radiology, and putting all these components together with the clinical picture to decide, is my patient worsening because of acute exacerbation of their ILD, or is it because of that relapsing organizing pneumonia, or is this actually more fibrotic progression? And then when in doubt, refer to the ILD centers. Like you said, we're more than happy to kind of work with you locally and co-manage your patients. We don't want to take over your patient care, because we know that sometimes people don't want to drive all the way up or can't drive. So we try to work with the local providers to give the patient the best possible outcome and best possible care.
When I can attest to that. I mean, for anyone that's in the Mountain West, University of Colorado is fantastic. And I have never felt like I'm not involved in the patient's care. I mean, it's always very, very collaborative. So thank you personally, because it's just, I've learned so much from you and Dr. Lee and Dr. Griffith. I mean, it's just been so incredible to share these patients with you and know that they're getting such amazing care.
Thank you.
Well, thank you so much for joining us for this episode of the ILD Community Network podcast. We hope today's discussion provided practical insights into distinguishing ILD progression from treatment failure to highlighted strategies for evaluating changes in symptoms, pulmonary function, imaging, and overall disease trajectory. A special thank you again to our guest, Jenny Williams, for sharing her expertise and clinical perspectives. The ILD Community Network is a collaborative initiative of APAP and RAP dedicated to advancing multidisciplinary education and improving outcomes for patients living with interstitial lung disease. To access additional resources, podcasts, expert insights, and community-focused programming, be sure to visit ILD Community Network website at ildcommunitynetwork.org. Thank you so much for listening, and we will see you next time.